Hello and welcome to the first in our series of 3 webinars on governing in an era of accountability, presented to you by Jim Rice of Integrated Healthcare Strategies and Kurt Waltenbaugh of Carrot Health. My name is Kelly Perkle and I will be the moderator for today's webinar. A couple of housekeeping items. All lines will be muted upon entry, and you are free to submit questions on the right side of your screen as they come up, but we will be answering the questions at the end of the presentation. Today's webinar is the first of 3 on the broader topic of governing in an era of accountability, with a focus on community health needs assessments and using data to enhance your community health. The second webinar will be on November 15th at 8:30 a.m. Central, and the third will be on December 6th at 10:30 a.m. Each webinar will open with 5 key messages and will end with 3 actions that boards should consider. Now I'd like to introduce our presenters. Jim Rice is the Managing Director for Governance and Leadership located at the Minneapolis offices of Integrated Healthcare Strategies, a division of Gallagher Benefit Services. He works with large and small hospitals and health systems to enhance the effectiveness of their boards and physician leaders, and has over 35 years of experience in integrated health systems in over 34 countries. Kurt Waltenbaugh is the founder and CEO of Carrot Health. Kurt has spent his career building and launching companies to better understand and influence consumer behavior, mostly at Optum, a division of United Health. Thank you both for being here today. Jim will be covering the first portion of our content. Please welcome Dr. Jim Rice.
Thank you, Kelly. As we can see on slide 3, a subtext for this first of 3 seminars is entitled Your Roadmap into Population Health. And the Community Health Needs Assessment is a critical tool we're finding as organizations ramp up their activities and investments and partnerships for population health, that this roadmap is often unclear and is often put together by a small number of people, where we hope it should be developed through a partnership with a wide variety of players. If we can go to our next slide, one of the things that we would like the participants in this webinar to keep in mind is 3 challenges that shape 5 messages we would like everyone to take from this webinar. In the bottom of this slide, you'll see the 3 challenges. We've found far too many board, physician, and administrative leaders are facing this challenge. The first is the leaders have become complacent with what the Community Health Needs Assessment is all about and the processes they use to develop and use those assessments. We'd like you to break through that complacency by adopting and adapting some of the ideas we'll share with you in this webinar. The second challenge is that tax exemption is a significant asset and resource for hospitals of all sizes. Our studies indicate that 3 to 5% of the average hospital revenues are dependent on this tax exemption. And we know now that without that exemption, we would be in financial peril, and the development of a community health needs assessment is a critical ingredient for that. The third challenge is that many board members have become focused and fixated on hospital utilization data, but may not have the experience or the sophistication to use other types of data in their planning and operational activities. Therefore, the 5 messages we'd like you to keep in mind is that a community health needs assessment is essential to help you move beyond tax exemption to fully leverage that exemption. The second message is the community health needs assessment is essential to guide and encourage and nurture your relationships with new partners along a continuum of care, and including partnerships that will help you deal with social determinants of health. The third message you'll be hearing from this webinar is that your mission-critical interventions for your mission of health engagement, health enhancement, service delivery, and financial vitality is increasingly dependent on how well you develop and implement your community health needs assessment. The fourth message is that behavior change is an essential part of the planning around community health needs. And finally, your capacity to develop payer and consumer leverage is going to be enhanced the more you embrace these new approaches to the development and use of your community health needs assessment. If we go to slide 5, we'll see some of the key elements that are involved in a community health needs assessment. It should look at both problems as well as assets within your community that can be harnessed and leveraged by your work. And the identification of these problems and opportunities become that roadmap to your future vitality. On the left side of slide 5, you'll see 4 types of messages that we would like you to keep in mind. Of course, all of this attention has been sparked by the Affordable Care Act, which is requiring nonprofit tax-exempt hospitals to develop a community health needs assessment at least once every 3 years. We, however, find it's going to be a more useful roadmap if you develop and use it every year. The actions that we'd like you to consider in this webinar is first identified around new partners that you'll be involved with. These are local boards of health, federally qualified health centers, schools, various public safety organizations, chambers of commerce, and the like. The second element that we've found so important for you to consider as you develop an enhanced and expanded view of the community health needs assessment is you're going to have to be prepared to use not only available data from within your organization, but new forms of data from the public health perspective and new social and demographic and psychographic data that we'll be referring to in this webinar. The third element that's important is to pay attention to the public health initiatives, not the traditional acute care hospital activities, because the move into population health and accountable care is going to be reimbursing and rewarding you to enhance health, not just improve health care. The final message on slide 5 is that as you identify health gaps and disparities in your planning process, you'll need to make sure that you map investments and actions to those gaps. So let's move now to the next slide, which is to look at some of the challenges that you're going to have to be facing. On the right side of this, you'll identify risk profiles of a wide variety of population segments. You're not just dealing with patients that present themselves to you through admissions or emergency department visits, but you're going to have to be looking at new risks for these populations, and your payment under the value-based scale will be increasingly using those kinds of activities. If we can move to slide 7, we'd like you to look at the right side of this slide and understand that if you're going to get full value out of your community health needs assessment, you're going to have to be prepared for new processes, new partners, and new investments. In the center of this, we see the community members that are going to be engaging with you in a bolder approach to community health needs analyses. Public health players, business, employers, nonprofits, philanthropic organizations, community development are all going to be at the table as you develop your plans. And moving around the outside circle of this, you'll find that you're going to have to be prepared to work more creatively in a cyclical process of engaging and analyzing. And as you do that, you'll identify a wide variety of interventions and investments that you'll see on the left side of this slide, which looks beyond acute care services into disease management, preventing and promoting better health through vaccinations, looking at behavioral health initiatives that you're going to have to be looking at, and very importantly, this confusing array of social determinants of health, which deals with the food security, housing, employment, and dealing with the underlying challenge of poverty. This is not an easy realm for us to be involved in, and so we'd like now to turn to some fresh approaches to look at the social determinants of health and those factors that influence that far beyond acute care.
Thank you, Jim, for the overview of community health needs assessments and some tactics and considerations to improve its effectiveness. We now would like to turn the stage over to Kurt Waltenbach from Care at Health, who will discuss the importance of data inclusion in this process. Kurt, thank you so much for being here.
Thank you, Kelly. So how do we get closer to the members of the communities we serve? Well, the first observation is that the vast majority of health outcome drivers are not clinically related. Why is this? The typical consumer only has about 3 encounters with a health professional each year. 40% of your community has 0 or 1. And of course, you may not have 100% market share and therefore not having enough visibility to the broader community at large. So the data within the health system is not representative. So how do we learn about those consumers? Well, we have to understand how they live their lives. What are the environmental concerns? Social, economic, behavioral. This is all information generated by those consumers participating in the world around us and is highly predictive of their current and future health status. So let's take a look at an example. People who live more than 5 miles from the nearest fitness option or park facility are more likely to be obese and have 20% higher emergency department utilization. Individuals who live closer to a fast food restaurant than a grocery store are at higher risk for developing diabetes. This information is the starting point for any good CHNA. So how do we transform that data into insights and actions and ultimately better health for the community? Well, each one of our consumers is different. We can't assume they all have the same needs, wants, risks, or behaviors. What they want from your health system varies based on who they are and their current status. So the CHNA becomes an excellent opportunity to create that baseline of understanding. Who are you serving in the community? Who are you not serving in the community? What do they need not just from the health system, but from health? This knowledge will begin to pay dividends many times over in guiding everything from strategy and growth opportunities to operational patient engagement, ultimately leading your entire community to better health. So moving from data into insights, actions, and results, start with what you know. Who are your consumers from several angles? Clinical, behavioral, financial, social, environmental. Start with understanding where they live and what challenges they're facing. Identify the gaps in the community and work to solve those appropriately both inside and outside the 4 walls of the health system. A great example comes from Cincinnati Children's Hospital, who used this technique to link poor housing conditions to childhood asthma. Instead of simply prescribing more inhalers and increasing ER staffing, they partnered with the community to address housing, code violations, and other issues related to mold, water damage, and pests, working to stop the problem at the source, not just treating the symptom. This CHNA Plus gives you a platform to generate these findings for your community, allowing you to create and match interventions to specific community needs. So case in point, let's take a look at Ridgeview Medical Center. This is a suburban, ex-urban rural healthcare system in the southwest of Minneapolis-St. Paul metropolitan area. Ridgeview Health needed a 2016 update to their original CHNA. Through this work, they recognized needs in the community that existed that were not being treated within the health system and used the results to create a roadmap for the market. One area elucidated by that CHNA that received a significant amount of concern and attention was mental and behavioral health. The community expressed concern in many ways across all age ranges, from middle school and high school students to elders and caregivers. So we start by mapping that need to identify pockets of concern. And one thing that we know here is that significantly more consumers are getting treatment in the northern edge of the service area, closer to the urban core of Minneapolis. Highlighted in the circles, access to care providers is one key difference, where you see in the green there is one mental health provider for every 320 residents versus the rural areas in red, where it's 1 to 4,700. This is a 1,500% difference in coverage in the metro versus the near rural areas. Yet the demand, the need by consumers, demonstrated by social vulnerability and substance abuse indicators per capita, is actually higher in the ex-urban rural fringe, noted by the two smaller circles down at the bottom. The results show a high correlation between mental and behavioral health diagnoses and social vulnerability. Behavioral health also correlates to income, living arrangements, and household composition. If you look in the highlights, in the circles, as consumers age, particularly in the lower income population, risk of mental and behavioral issues increase. Similar correlations exist with tobacco and alcohol usage. Understanding these details about where the risks are allows you to reach out and intervene appropriately with the right audience. So some of the takeaways here: connecting social needs, income, housing, and demographics to mental, behavioral, and substance abuse needs allows us to identify the at-risk population both inside and outside our health system. Once identified, we can begin to put services in place to meet those community needs and demands through, in this case, maybe telehealth and online, rotating clinicians into outlying areas, messaging to at-risk consumers, partnering with external entities in the community, and much more. So let's hear what Bob Stevens, CEO at Ridgeview, had to say about the process.
We work with Carrot Health to look at our community health needs and assess those needs based upon a couple of really unique aspects. First was using our own electronic health record data. So Carrot extracted all these data points out and then overlaid it onto the demographics and other information we had on our marketplace. It was probably one of the most comprehensive and dynamic assessments we've ever done on our marketplace, our population, and our own patients. I think one of the most intriguing aspects of this data was it helped us prioritize where we had opportunities to improve population health, and it also did it geographically. We knew that we had pockets of care that needed to be addressed based upon the geography. So from our standpoint, we could target our resources better based upon really valid information. I think the big success story is we finally got to use our electronic health record data in a robust way, not just for the clinical treatment of an individual patient, but looking at an entire population of people. We work with Carrot Health to look at our community health.
So the key here is that last statement. We finally got to use our electronic health record data for population health. After all that investment in an electronic medical record, it was not useful for population health, for the overall community, until we combined it with information about the people who live and work in that community. Taking your EHR data from inside the four walls and adding external behavioral, social determinants, and other factors outside the four walls in the community allows us to understand and address the broader needs, to create a roadmap for addressing the most pressing needs of the system instead of simply treating the symptoms.
Thank you very much, Kurt. We'd like the board, physician, and administrative leaders that are participating in this webinar and those that will review it later in its recorded format to recognize that the real value of taking a fresh approach at community health needs analyses and planning is going to be a challenge for us. We hope that you keep in consideration these 5 messages. Your tax exemption is dependent on doing these, and your economic vitality and your mission central focus is dependent on doing it better, faster, brighter, with more people in the future. The new approach that we're encouraging you to take for community health needs analysis is to develop new partnerships, to look at new forms of investments that will drive your new capital as well as operating budgets in different ways for the next 3 to 5 years. You're going to have to become more involved in behavior change and the factors that influence that. And very importantly, they will shape how you can better serve your consumers and payer needs, and in the process gain leverage in those relationships long term. So to operationalize these messages, let's encourage ourselves to take 3 important actions by the board and medical staff and executive leaders. The first action is to evaluate what you've been doing in the past. We have many interactions over the last several months with boards that feel, well, we've already been doing community needs assessment, and what can we really get out of a new approach? And in the process of taking a candid and objective evaluation of what you've done, who's helped you develop those, and whether you're in fact walking the talk of these initiatives, we hope that that honest assessment will stimulate you to take a fresh approach along the lines that we've been encouraging in this webinar. The second of 3 actions is to expand your understanding and your approach to community engagement. There are many more participants that should be sitting around the table with you. We have worked with large community and urban hospitals as well as smaller rural community critical access hospitals, and their participation and quality of planning goes up when they meet with the public safety officials, the chambers of commerce, the schools, local boards of health, and the like. Develop a protocol that is driven to listen to these participants with their psychographic insights, but also new data that is driven by population measurement, and take a fresh approach to the metrics that you're going to be using for planning, and very importantly, metrics that will help you monitor progress to plan once you start implementing and investing in bringing life into and through that community health needs assessment. The third action we would encourage you to take into consideration is to establish clear and measurable goals and help define new roles of the different participants that have helped you develop the plan and are essential to implementing the plan. Hold yourself accountable. Walk the talk of the gap analyses, the disparities that you find, and the initiatives you take to bridge the gaps and to reduce those disparities. Invite tough questions from yourselves and the community partners that you're engaged in this joint planning. Be honest about your progress, but also celebrate the progress that you're making. Many of you are aware that I'm based in Minnesota. We have a large number of Catholics and Lutherans in Minnesota. We're very good into guilt, but we're not so great onto celebration. So one of the things that we'd like you to keep in mind as you start implementing these plans is find ways to celebrate the small steps and the progress that are being made by the different participants. The result of taking these 3 actions, we believe, will not only be a higher quality and more robust community health needs analysis, but you're going to be poised to improve community health and, very importantly, sustain and drive toward economic vitality, because you'll have much more effective relationships with your payers, both public and private. You'll also find the capacity to attract philanthropy to help you initiate these activities will increase as well. If you turn to slide 19, we have resources, and so Kurt and Kelly, I'm looking forward to our conversation now about how to take advantage of these ideas.
Jim and Kurt, thanks again for your valuable insights and ideas today. As Jim mentioned, you can see on slide 19 a list of resources with some live links that will be accessible when we send out a follow-up email, including the link to the recording and a PDF copy of the presentation to ensure you have access to all of these materials and lists of resources. We'll now open it up to questions from the audience. Again, please use the question and answer panel on the right side of your screen to submit questions. Those will become viewable to us as panelists. And we've got a couple coming in. Let's start with Jim. Could you please clarify the value of the tax-exempt status you mentioned earlier in the presentation? We all know this is an important aspect of the not-for-profit status, and why is that something, as far as the value goes, that you recommend a board pay attention to?
Thank you, Kelly. Many of us that have been engaged in the benefits reporting for community benefits that we used to have as our guideline from the Internal Revenue Service to keep our tax exemption have recognized that there is real value in doing the planning for community health and better health care, but as a result of the enactment of the Affordable Care Act, we now have some more explicit pressures on us to understand what is the economic value of the tax exemption. We've just finished an analysis of the importance role that the board plays to protect that exempt status. That analysis, if there is interest from participants in this webinar, we can include that and send it out to those registered. But we analyzed studies that have been conducted over the last 5 years by a number of academic and governmental agencies about the percentage of a hospital's revenue and expenses that are dependent on that tax exemption. Exemption, of course, as we all know, is exempt from property taxes, sales tax, a variety of other taxes. And the analyses have shown that this is worth 3 to 5% of the operating budget of a hospital. So you can calculate what 3 and 5% of your last year's operating budget is, and that represents the economic value of that exemption. It also should suggest the threat to you if you're not able to continue to earn and justify your exempt status through your use of community health needs analysis and the many other initiatives that you're involved in terms of health care, education, and perhaps research. So there are a number of analyses that have been conducted, and for the average hospital that may have approximately $100 million of revenue, it's easy to determine the value of $3 to $5 million a year from the exempt status. So don't take it lightly, and address it in a more explicit way as you approach planning for your community health needs.
Great advice for our listeners. Thanks, Jim. Kurt, a question for you related to data access. How do you recommend we get started accessing the information needed to expand our CHNA efforts?
That's a great question. Thank you. So the starting point is to take the information that you have about your consumers, your patients, and match that up with information about how they behave in the community. And so there are a couple of sites, some of which we've listed on the handouts here. Community Commons gives you a great place to start to pull some high-level sort of zip code and county level information. There are a number of other organizations that provide similar data out there that you can go and use to give you a baseline for that health needs assessment. The challenge, though, is driving down it to a more detailed level to get from the zip code and the county level down to the individual consumer, the individual household, the participants within that household, and look at the differences on a house-to-house basis. And just one example, so as we look at individuals from one house to the next within a community, we can differentiate them by their social vulnerability, the risk of social isolation and other factors that might cause them to have some downstream health issues. The individuals who fall into the top decile of that social risk, 52% more likely to have 4 or more emergency department visits a year, 28% more likely to be diagnosed with diabetes. And this is information that at the individual level is very, very predictive, but at the county or zip code level gets lost. So to get there, there are sources where you can pull data from commercial data brokers. You can look to data.gov from the federal government. You can look to dozens of sources across the country which will allow you to build up that risk profile. You can also, if you choose not to do that on your own, you can work with commercial entities like Carrot Health and others that would provide that service for you.
Kurt, that's very helpful. I have a question for you. Maybe we could have a little bit of conversation about how we make this information come to life for board members. These are community leaders. Often they come from a background in banking, perhaps in agriculture, and a variety of other responsibilities that they have as community leaders. We recently conducted a health needs assessment in a rural area, and some of the board members weren't too comfortable with some of the use of the data. I wonder how, as you go across the country when you're interacting with board members, what's the level of interest they have and what's the level of preparedness they have to use new forms of data to think about the needs of their neighbors and their colleagues in their communities. Why don't we have a brief conversation about their readiness of these boards? What are you seeing in the interactions with boards and, for that matter, the leadership teams of hospitals?
Great question, Jim. The challenge, I think, is there is obviously, as you alluded to, questions and concerns around the laws surrounding HIPAA and data privacy and how that information can be applied to these populations. We certainly don't want to use clinical or medical information in ways that are not permissible or make our patients uncomfortable. That being said, I think one of the challenges for boards is to understand that many of these techniques are things that are in use every day by retailers, by financial services industries, hospitality, and others to understand their customer and potential customer populations. There's nothing in here that is off limits to a health system to say let's not use the same techniques to understand our customer population and use that to provide better services and better care into the community. So you have to make sure that you're taking the appropriate care to protect the information, but also to use those insights to drive your strategy and your roadmap forward. One of the challenges that we can see in organizations is a tendency to kind of throw up our hands at HIPAA and say, well, that prohibits us from doing everything. Well, that's not true. HIPAA still wants you to be able to understand your community and provide those services in a targeted way.
Thanks very much.
We have another question coming in, gentlemen, about the relevancy for those organizations that may have completed their CHNA earlier this year or recently, and how this new approach could still be relevant before waiting the full 3 years that is required.
Thanks, Kelly. I'll respond first, and then maybe Kurt can step in as well. I mentioned in my remarks that we would encourage boards to think of doing something every year as it relates to community health needs analysis and certainly reporting on progress to plan. While it is the minimum requirement is one of these analyses every 3 years, your contract arrangements with payers are often annual. Your measurement and reporting of consumer satisfaction that use your services that you have to report to the federal government is annual. And so we would encourage boards and physician and administrative leaders to think of annual initiatives, even if it's not a complete comprehensive update of the needs analysis. There are many types of studies that could be done each year. You may elect in 1 year to do a deeper dive into teenage pregnancies that may be creating a public health challenge in your area. And another year you may be looking at some of the gaps that you identified last year in immunization rates and what could be done in an urban area and perhaps in a rural area to work with the schools and to work with families and to work even with faith communities to enhance awareness of the value of immunization and how to reach out and engage them. So my first response is that you should be doing something every year that is related to the analysis of community health needs analysis and planning to do deeper dives into interventions and initiatives that would be helpful, and then, of course, celebrating progress to plan along the way.
Yeah, great example. I have an example from a health system. A board member in Colorado approached us recently with an example of their CHNA that was done for 2015, and we had a conversation about that. And I think the challenge with the prior version, it was more of a what we call a tick-the-box CHNA, where they interviewed a small number of participants in the community. One of their focus groups had, I think, only 8 or 9 people who attended, and they used that information to come up with some generalities around the population and who they're communicating to. We're challenging them to update that in 2016 and take a broader data-driven approach to assess the needs of the entire community instead of generalizing with a very small sample set across the needs, which fundamentally, and this is, I think, one of the challenges for boards that Jim alluded to, when you're only shown a small portion of the information, you end up relying on biases and assumptions for decision making as opposed to driving that based on the actual demand and need in the community.
One other thing that I've found important and I'd like to share with the participants on this webinar, I recently moved back into domestic health activities after working for the last 4 years in Asia and Africa and Latin America. And I was frankly surprised and a bit dismayed that many of the boards and the physician leaders that we started working with had this newfound religion about population health, but were wanting to use the same old approaches to needs analysis to look at these population health challenges. And they also felt that they had to do it themselves. And one of the messages that we hope folks take away from this webinar is rely on people that have been laboring in this vineyard for many years, the local health boards, the public health departments, federally qualified health centers, the schools. We shouldn't try to have all the answers, but we should engage with others to frame the questions and then look at co-generation of answers to those questions that make sense for our unique community and our capacity to make the investments to yield health gain as well as health care.
Kurt, a specific question for you related to technical requirements. So are there any specific requirements for the EMR that you would need in order to use the data in the way you described, layering it with additional demographic and other social data that you have access to?
Good question. For the most part, EMRs are very good at storing information at an individual patient level and an encounter level and using that information from a billing and claims process perspective. What we find they're lacking is the ability to roll that information up and look at it across the community, and they don't have the facility to look outside of the patient population at members of the community who have not visited the health system. So we start by taking that information out of the EMR and running that through a process to match it up to retail data, purchase pattern data, behavioral, financial data, credit background check information, and that gives us information on the current patient population and then allows us to map that to non-patients within the communities. So from an EMR perspective, it's usually a very straightforward, simple task to get into the data and create an extract or a report that can be pushed out as a starting point for the analysis. So the actual reliance on the health system's IT staff is very small.
Great, thank you. I think we have time for one final question, and it's a good one for each of you, Kurt and Jim. What 1 or 2 actions do you suggest that a hospital board or leadership take to become more educated and prepared for the process of undertaking their next CHNA?
Thank you, Kelly. I think there's probably 3 or 4 ideas that I would encourage us to consider and to talk about at our board tables and in our executive lounges and medical staff lounges. The first is to acknowledge we don't have all the answers, so be prepared and be enthusiastic about inviting in new people to share their ideas and concerns and resources from different segments of the population. Certainly we need to invite in speakers to inform us about concerns and needs that they see. That qualitative color is going to be very important as we look at the planning and identification of gaps. So that's one of the three I would suggest. Invite in speakers, and speakers that make you uncomfortable from different gender, ethnic, racial, demographic segments. Invite them into our board meetings and look at these challenges and their ideas of solutions. The second, going back for 20 years, there was a lot of discussion about a community plunge where board members actually go out into the community. They do bus tours and walking tours to see where the challenges are firsthand and not make it an antiseptic or academic understanding of the challenges and needs. So that would be the second of three that I would encourage us all to pay more attention to, the community plunge. The third is to look at some joint planning. Too often I've seen in our work with the Foster McGaugh Award Program, which provides a $100,000 prize to the community hospital that demonstrates they're walking the talk of community health engagement and health gain enhancement as well as health care improvement. And that is the opportunity to work with new partners and to do that planning not just with these other community leader organizations, but do it with your competitors. Other hospitals, other large multi-specialty group practices must be involved in this process if we're going to help get the process to be more accurate and more understood and therefore owned so that we can implement them.
I would add to that two things that we see. So as you're evaluating your CHNA process and looking at across the qualitative data that you've captured through surveys and community meetings and the quantitative data that hopefully you're capturing through surveying the broader community, I would ensure two things. One, that we're not simply looking at past behavior. We're not looking retrospectively to say, here's what the needs were in the community last year and the year before, but make sure that you're projecting prospectively into the future. What are the needs today and where are they going to be? Think down the road as to how the demographics and the populations are changing and what are the future needs that we can build for and plan for in our strategic plans to meet those needs of the communities down the road. And then the second piece, make sure that we're not just focused on our current patient population, but the people outside of our patient population in the community who have health needs who aren't getting care from us as a health system today that probably need to be. So let's look outside of the current world and say who else needs care and in the community that we can address down the road.
Jim and Kurt, thank you for sharing your wealth of knowledge with us all today. And everyone on the line, thank you so much for your participation and your great questions. We look forward to seeing you back here for the second and third sessions of this seminar series on November 15th and December 6th. Again, all participants, you will be able to watch this recording again on our website in the near future, and we encourage you to forward the information and content to your colleagues who you think would benefit. If you have any further questions, our email addresses are located at the bottom of the page, and we welcome your thoughts and questions as we all move forward in this era of population health together. Thank you, everyone, for your participation.